All right, good morning. My name is Liz Palyu. I am the Director of Clinical Services for Peak Behavioral Health. How's everybody doing today? Good, awesome. All right, so I am going to talk about continuum of care and recovery. When I talk about recovery, I'm talking about anything that's mental health, psychiatric disorders, and substance abuse. And the reason I wanted to discuss this topic today, because all of you that are here, including us at the Peak, we work very closely with individuals who have psychiatric disorders, mental health disorders, substance abuse disorders, and we all know that when they go into treatment, the likelihood of them going through that revolving door will continue if they do not have care that goes beyond what we provide for them in our own facilities. So what is a continuum of care? So continuum of care can be a single thread of treatment, begins with whenever an individual chooses to enter professional treatment and carries through aftercare and beyond that. It summarizes a standard of treatment that are proven to be most effective, namely care should be taken over a significant period of time and eases a patient back into independent life. Through a continuum of care, it allows our patients to step down to less intensive levels of care to continue their recovery. And with a continuum of care model that we're going to talk about today, the patient has multidisciplinary teams that personalize and adjust the care to meet their unique needs. An ideal continuum of care has a wide array of services that span out from professional services out to support services. And that will also identify what the patient's needs are and meet those needs on every spectrum. All right, so in a medical model, we already have a continuum of care, and we've had it for a very long time. It's called a recovery management. It describes a shift from an acute model that treats medical conditions in an intense short-term manner to a chronic care approach, which reflects a commitment to long-term wellness for medical conditions. So individuals with heart disease, individuals with asthma, with diabetes, individuals with cancer. It describes a shift, going to the next one. The public health community has long practiced recovery management when treating chronic diseases. And while the public health care providers may use different terminology, recovery management is a tool embedded in their approach to practice. The public health principles address health promotion through comprehensive prevention strategies, screening, early intervention, treatment, and enforcement of healthy lifestyles. So I want you guys to imagine this. If you had a heart attack patient who is sent home after their crisis incident without any cardiac rehab, what would most of you all think of that? Someone comes in, they have a heart attack, and then we just send them home. No referrals, no cardiologist, no follow-up care. Most of us would consider this to be pretty dangerous and unsafe, correct? Okay, so many things can go wrong. The possibility of deadly consequences in a heart attack patient that is not provided with ongoing follow-up care are pretty high. Yet, most people with mental health illnesses and substance abuse disorders receive exactly that fragmented care that results in life-threatening consequences as a result. So today, we want to go ahead and go over the statistics and all of the things that we can do to help prevent this from happening from the people that we provide services to. So, considering the statistics, and I'm going to bore you a little bit with statistics, but I'll give you an overall view of what we're looking at. By 2020, mental health and substance use disorders will surpass physical diseases as a major cause of disability worldwide. The annual total estimated societal cost of substance abuse in the United States is $510 billion, with an estimated 23.5 million Americans aged 12 and older needing treatment for substance abuse disorders. There are 34,000 Americans that die every year as a result of suicide, approximately 1 every 15 minutes. Half of the lifetime cause cases of mental and substance abuse disorders begin at age 14, 3/4 by age 24 in 2008, and an estimated 9.8 million adults in the US have a serious mental illness. Studies show that 20% of people who transition without continued care will avoid relapse after 1 year. Adding continuing care increases that recovery rate by 50%. So some adult statistics: 57.2% of adults with mental illnesses receive no treatment. Over 26 million individuals experience a mental health illness are not being treated. The state prevalence for Vermont is 40.7%, and California is 64.8%. Almost a quarter, which is 22.3% of all adults with mental illness, reported that they were not able to receive the treatment they needed. This number has not declined since 2011. For youth, almost 50% of youth are still not receiving the mental health services they need. 59% of youth with major depression do not receive any mental health treatment. 10% of children and young adults 5 to 16 have clinically diagnosable mental problems, yet 70% of children and adolescents who experience mental health problems have not had appropriate interventions at a significant early age. 1 in every 6 US children ages 2 to 8 years old, which is 17.4%, had a diagnosable mental, behavioral, or developmental disorder. 20% of adolescents may experience a mental health problem in any given year, and 50% of mental health problems are established by age 14 and 75% by the age of 24. Those are some pretty high numbers that we're looking at. And when we provide services to our patients and we don't continue those services, they tend to come back in. So our numbers may actually look higher than they are because we're repeating the same patients that we already provided treatment for. These patients are through that revolving door because we don't provide a continuum of care that is significantly longer than the couple of months or maybe a year that they spend in a treatment facility or an outpatient provider services. So individuals seeking treatment but still not receiving needed services face the same barriers that contribute to the number of individuals not receiving treatment at all. And these are some of the barriers. There's no insurance or limited coverage for services, a shortfall of psychiatrists, and overall undersized mental health workforce. We're all very familiar with that. A lack of available treatment types, so inpatient treatment, individual therapy, intensive outpatient, and community services. There's a disconnect between a primary care system and a behavioral health system. For the most part, there's very few primary care providers that are linked up to your psychiatric and mental health providers, so they can bridge that gap between the two services. Insufficient finances to cover costs, and this includes your co-pays, your uncovered treatment types, and when providers do not take a specific insurance. And the state prevalence of adults with AMI reported unmet treatment needs ranging from 14.3% in Alabama to 31.2% in Utah. And unfortunately, I wasn't able to pull statistics for New Mexico or El Paso, but overall, we're looking about the same across the nation. So we're going to look at some overlapping problems and collaborative solutions, because we all know that it's not just one issue, right? It's not just depression. It's not just substance abuse. It's always something that comes together and overlaps with something else. So in the past, practitioners and researchers saw substance abuse as a very distinct from the prevention of other mental health illnesses. Mounting evidence does indicate that populations affected by the problems overlap significantly, as do the factors that contribute to these problems. Consequently, improvements in one area often have direct impacts on the other. Many young people have more than one mental health disorder. These disorders can interact and contribute to the presence of other disorders, leading to concurrent diagnosable disorders and comorbidity. An estimated 30% of alcohol abusers and 53% of other drug users have also been diagnosed with at least one serious mental illness. Despite extensive research documenting strong associations between multiple problems, it's not always clear what leads to what. For example, you can have a substance abuse lead to thoughts of suicide, or the thoughts of suicide can lead to substance use, or they are both a product of a third unknown causal factor. One of the individuals with a diagnosable mental health disorder also suffer from substance abuse disorders. So recognizing those linkages, mental health and physical health are also connected. Everybody knows that when you have issues with mental health, emotional health, it affects us physically. We're unable to function on a daily basis. We become physically ill with medical conditions. So good mental health often contributes to good physical health. Similarly, the presence of mental health disorders include substance abuse and dependence is often attached with physical health disorders. A large number of studies provide strong evidence that drinking alcohol is a risk factor for primarily liver, breast, and colon cancer. So positive lifestyle adjustments, however, like sleep, diet, physical activity, and fitness can also significantly strengthen mental health. A prevention practitioners are responsible to be mindful of these linkages and see our work as part of a broader effort to improve overall health. And so all of you that work with substance abuse, mental health, psychiatric illnesses know that there is that connection, right, between mind and body. And through Continuum of Care, we're also paying attention to mind and body. We're paying attention to how those linkages affect whether or not a person can recover. And so through Continuum of Care, we're hoping, and this presentation, we're hoping that you all can also find different resources that'll help connect those areas and help prevent that revolving door from for a patient. So recognizing the linkages can help identify opportunities to address health in a more comprehensive way by working across disciplines, pooling resources and reaching people in those settings and during times when in their lives where and when services are most likely to have an impact. Okay, so we're going to talk about 3 predictors of long-term recovery success. 3 main factors that predict whether someone will recover from mental health and maintain their recovery over a long period of time. Support and stability of loved ones, engaging in longer periods of professional care, and societal and community support like organized support groups. If the care is not continuous, there are numerous places where someone can discontinue care and fall out of recovery. As a result, the cycle may start all over again. We don't get to start where they left off. We start where they first began. So benefits of providing a continuum of care. We request and help support providers to implement programs that bridge care at every stage of recovery process, including after their client returns home. Oftentimes we see patients go into any level of care, and when they return home, the services either stop because the patient decides that they no longer want it, more likely than most times, or because services are not available to them to continue. You know, your treatment services are only so long. In an acute level of care, you're 7 to 10 days. In a residential rehab program, 28 to 30 days. What happens after a patient leaves those different types of services? And if they were to even go to outpatient services, those are limited too, right? You can only see your therapist so many times in a year, or your psychiatrist so many times in a year. So what do we have to help bridge that gap? Because that's what's going to help keep that patient in a recovery mode. So an example, a patient in crisis in the ER hospital may be immediately referred to an acute level of care facility where they become physically and emotionally stabilized. This is your 7 to 10 days. Before they leave that acute level of care, the patient care team will identify a safe placement with aftercare services, such as a rehab. Maybe they're not willing or unable, or for whatever reason not able to go to rehab, so we set them up with partial hospitalization programs or intensive outpatient programs. Clients that receive the follow-up plan when returning home include the resources they can use while transitioning to everyday life. Everyday life means, do I have the means to survive? Because a lot of the times our patients that do not follow through with care are because they're trying to survive. Basic needs: housing, transportation, childcare, food, electricity, water, work, employment, education. All of those different things contribute to whether or not a patient can manage and maintain on a path of recovery. So the patient can be offered many aftercare services that can carry the person through a lifelong recovery after their treatment. And many people involved in helping these patients return to health and productivity after they decide to treat their mental illness or addiction, the people in recovery themselves do the hardest work, okay? Without proper support throughout their journey, the possibility of relapse looms extremely large. So here are your windows of opportunity. And this is for everybody, for all of us to be able to kind of start to reach out and figure out where our windows are and who can we reach out to get the help that we're so much seeking for our patients and client populations. So half of all behavioral disorders appear during adolescence. So we can catch these at an early age. We have a greater opportunity to provide services in a continuum of care and get them to recover before their adulthood. While the average age of diagnosis varies by disorder, the first symptoms of most behavioral health disorders typically occur 2 to 4 years before they're diagnosed. In a case of substance abuse disorder, for example, initial symptoms appear around the age of 14. About 4 years later, when the symptoms progress to a point of a diagnosable disorder, they're already 18 and adult, correct? If we intervene during these windows of opportunity, during the period between the time when the symptoms first appear, the disorder can be diagnosed, and we are more likely to prevent the onset of the disorder and produce lasting and long-term impacts. And if we can intervene even sooner and promote healthy lifestyles, our potential for reducing the toll of the behavioral health problems on the individuals, communities, and society is even greater. All right, so this is just a quick example of a continuum of care for psychiatric mental health care. The first is your primary care provider, specialty care providers, patient-centered medical health homes, community clinics. All of those are your first level. Then you go to transition to outpatient treatment. So psychosocial rehab programs, clinical case management. You also have psychiatric home care, assertive community treatment, which is your ACT programs, intensive substance abuse programs, partial hospitalization programs, and your most acute treatment would be your emergency room, your crisis stabilization, locked inpatient. For us at Peak, and probably for most of you, most of us start to see those patients at the very bottom when they're already in that crisis situation. So we've missed all of those opportunities at the top already. But if we can start to focus on what's at the top and even move ourselves backwards when we have somebody in a crisis mode and start to move ourselves backward and say, now you're in a crisis situation. Let's get you out to an assertive community treatment program. Let's get you out to partial hospitalization program, IOP programs. Let's get you some case managers that can help manage your case and find all of the nooks and crannies that we can fill, such as transportation, because that's why you don't go to your outpatient providers, or you don't have childcare, so let's find some way to get some childcare for you. All of those things combined will help an individual to be more successful in their recovery. This is another example. This is for child and adolescents. It's a little more detailed because we do have a little bit more to provide and offer in our facility in our state with adolescents. But again, you're looking at outpatient care, intensive outpatient programs, partial hospitalization programs. Those are all your day treatment programs. Residential treatment used to be something that we had a whole lot of in the state of New Mexico. Treatment foster cares, we had a whole lot of those in the state of New Mexico, and those are dwindling pretty quickly. So now we are even looking at what do we do when those services are no longer available and we still need to have a continuum of care for these patients. And so we rely on inpatient and outpatient services such as your day programs. We also look for services such as wraparound services, which is very important because wraparound services and MST services, they don't just work with the patient. When you're working with adolescents, you've got to look at the bigger picture. Their school, their parents, their siblings, their friends, and these types of services will actually go out to the school and into the homes and try to figure out how we bridge those gaps there as well. So important services on the continuum would include scale of intensity inpatient treatment that progresses from minimum engagement to full supervised intensive care. Describes patients who needs around-the-clock medically managed intensive inpatient monitoring by professionals. Here are some of those important services. Your inpatient hospitalization. Your highest level of care is reserved for people who need most intensive services under the supervision of a team of professionals. It is short-term and frequently found in an acute care hospitalization. And this short-term is 7 to 10 days. All of us know that we cannot really make a true impact in 7 to 10 days, especially when we go back to the statistics and see that an individual first symptoms started around the age of 14, diagnosed around the age of 18. We cannot do a whole lot in 7 days when this individual has suffered 4 or more years, right? We know that it has to go beyond that 7 to 10 days. So we look at inpatient residential type treatments. This is a longer duration than inpatient hospitalization. It can last from 28 days to 1 year. The programs are still, they still provide 24-hour care from trained staff, but they are a little bit more freedom and relaxed for the patients to actually start working on themselves and what they need to work on. Then we move down to a partial hospitalization program. A PHP will provide outpatient treatment 5 days a week for 4 to 6 hours each day. The person will live and sleep in their own home, and the level of treatment is matched to the person who needs structure and consistency, but are not needing an inpatient environment where they're being supervised and watched 24 hours a day. This type of outpatient care allows a patient to know that for 5 days a week, they have somewhere to go and someone that they can rely on for support for those 5 days a week for those 4 to 6 hours a day. Intensive outpatient is your step down from that. If PHP is too much or they've already completed the PHP program, the IOP could be the next option. There are usually 3 hours of treatment 2 to 3 times a week. And in all of these treatments, they do receive individual services, groups, support, case management, psychiatric services. Then you have your standard outpatient therapy, which consists of an hour-long therapy session ranging from several sessions each week and only one session each month. It can also include teletherapy services that we are now seeing so much of. Your general aftercare services will help with coping skills for triggers, relapse prevention, extra resources, peer supports, and these are things that'll help you stay sober, help manage healthy living, fulfill life once you have left a particular facility or an intensive program. Now, these are your most common that you're going to see all the time, right? With any facility that you're at, that you're going to be seeing this kind of a discharge for a patient. Care management services is going above and beyond. And it's looking across the entire continuum and accessing supports that are specific to the individual, identifying a myriad of resources that can be used to foster recovery. So this is where we're getting into how do we make sure our patients have what they need to survive? Because without that survival needs being met, they're not going to focus on recovery. Survival comes first all the time. So we can link individuals to care management supports, case managers through facilities, through insurance companies. There's all kinds of local facilities that will provide that for them. And what they do is help them find a place to live, help them find ways to help pay their rent and their utilities, to get food, to get childcare. Because without these things, your patients will fall off of the recovery path. They won't go to appointments. They won't follow through with aftercare services, therapy, med management, because these things are much more necessary than those appointments because it's a matter of survival. Other support services, we have the peer mentors, the recovery coaches that are available through a wide array of facilities, agencies. There's even a lot of, through the insurances, a lot of telephonic and telemedicine supports that are available through the insurance companies now. And there's coaches and there's peer support workers that you guys can help your patients access to have someone to text. It's a simple text on how they're doing every day and what they're struggling with today. So those are kind of things that will kind of link and provide that continuum of care for your clients. Suicide continuum of care is extremely important, and oftentimes we see individuals who have made a threat of suicide, who have attempted suicide, who have suicidal ideations. We provide them base treatments, but discharged patients viewed as being high risk of suicides require immediate community follow-up. Mental health services should be mindful of discharging patients after a short admission. The potential of detrimental life experiences indicates the mental health clinician needs to be aware of the circumstances into which the patients are discharged. Use of enhanced levels of care, such as that offered by a care program approach, may play a strong role in preventing suicide within 2 weeks of discharge. An immediate post-discharge period is a time marked of risk, but rates of suicide remain high for many years after that discharge. Patients admitted because of suicidal ideation and behaviors and those in the first months after discharge should be a particular focus of concern. Previous admission patients should be able to access long-term care and assistance. We do see that, again, we refer to outpatient services. We make sure they have a counselor that they're going to see in a couple of days. We make sure they have a psychiatrist they're going to see in a couple of days. But a couple of days is a really long time for somebody contemplating suicide to see someone and talk to someone. And so this is where we want to look at what other options do we have? What other resources do we have available? And peer mentors and coaching is a really good way to provide that to our patients. Insurance companies also have care coordinators or care managers that are available. And these are great individuals that can link the patient to other services, support groups. They can link them to AA groups, NA groups, things like that that are available in their area. They call to make sure the patient is okay. They call to make sure the patient knows that they have an upcoming appointment. They call to make sure they have transportation to that appointment, and if they don't, then they will help them make arrangements through the insurance company. So these are all different supports and links that we can use as part of this continuum. So behavioral health continuum of care model. This model helps us to recognize that there are multiple opportunities for addressing behavioral health problems and disorders. Based on mental health intervention spectrum, first introduced in 1994 at the Institute of Medicine, the model includes 3 components. Promotion. These strategies are designed to create environments and conditions that support behavioral health and the ability of individuals to withstand challenges. Promotion strategies also reinforce the entire continuum of the behavioral health services. The prevention, delivered prior to the onset of the disorder. These interventions are intended to prevent and reduce the risk of developing a behavioral health problem, such as underage drinking, prescription medication misuse and abuse, and illicit drug use. Then there's treatment. The services are for people diagnosed with a substance use disorder or other behavioral disorder. And maintenance. The services support individuals' compliance with long-term treatment and aftercare. Now keep in mind, however, that interventions do not always fit neatly into one category or another. For an example, consider comorbidity. If some disorders like substance use are high-risk factors, for other disorders like depression, does that mean that all treatment can be seen as a prevention? So each prom season, just as an example, communities across the nation implement safe driving campaigns as they're promoting healthy lifestyles and preventing potential substance use. But are they doing anything to address the underlying issues that might be contributing to that substance use? So we're going to look at the patients that fall through the cracks in the systems. These are the ones that go through your revolving door. These are the ones that help our numbers stay high. An effective physical, behavioral, or mental health treatment plan must include an evident and streamlined continuum of care to provide the best possible treatment. A solid continuum of care is especially crucial for individuals receiving treatment for mental health illnesses and substance abuse. And without treatment in a continuum of care, patients are more likely to fall through the gaps in the system, which results in poor care and increased likelihood of relapse, overdose, suicide, and other difficult outcomes. Transitioning out of any inpatient treatment is a challenging time, and when there's not any other service in place, the person's recovery is at greater risk. A patient may go through a medical detox during an inpatient hospitalization, then have to wait weeks or months before getting into a rehabilitation program. May never get referred to a program at all. A lot can happen in those few weeks or months, and any number of addiction issues can land a person right back in the hospital, in jail, or worse. So likewise, when someone returns home from a typical 28-day drug and alcohol rehabilitation program, more cracks can open up if the follow-up plans are not in place. For many people, going home means returning to the people who have no interest in supporting them in their recovery. And we know that to be true, where we send our patients home back to family or friends, and they're not, that's part of the issues that brought them to us to begin with, right? Their environment. Environment plays a huge role in why our patients continue to suffer. But that's where they end up going back to. So that's something that we can always prevent, but it is something that we can provide additional supports for, so that when they're feeling upset and feeling like they need to use again, feeling depressed, feeling or having thoughts of suicide again, can we link them to someone else they can talk to? Someone that's outside of the family, someone who maybe has already heard and been through all of this with our patient, because that's their family member and it's an ongoing process. So someone else that can help them out. So your care coordinators, your coaches, your therapists, things like that can be that outside resource for them. Lack of follow-up can also cause them to lapse into old habits, resulting in another acute crisis. And then again, we start that process all over again. And the worst case scenario, persons will overdose following their period of sobriety or suffer grave physical effects. So this is how we work across the continuum of care model. It reminds us to think more explicitly about the relationships between promotion, prevention, and treatment. All too often, these relationships are overlooked, all opportunities for collaboration are missed, and outcomes are compromised. Here's another example. To address increasing rates of underage drinking, an anti-drug task force in a small New England town decided to strengthen enforcement to underage drinking laws. Police began arresting youth that they found attending underage drinking parties and arrested the youth. The arrested youth were required to receive an assessment for their substance use and attend a 6-week education program provided by the local substance abuse and mental health agency. The intervention was effective on the prevention end. Knowing that the threat of the arrest was real, fewer youth attended underage drinking parties and underage drinking. But what about the effects of the related treatment services? The increased law enforcement efforts produced an increase in the number of referrals to the local substance abuse and mental health agency, as well as a change in the type of referrals. Prior to the increased enforcement, most of the youth referred to the agency were at high risk for substance use. The youth received selective interventions tailored to their needs. Now, most of the referrals were youth who were much lower risk. Their needs were significantly different. So recognizing the potential impact of its new enforcement policy, the task force worked closely with administrators of the treatment agency to prepare. Knowing what was coming down the pipeline, the agency was able to more appropriately allocate resources and address the diverse needs of all of its referrals. The collaboration and the more comprehensive approach to the problem of underage drinking produced a better outcome overall. So you see where they took that their one goal was to stop the drinking at the house parties, right? But that expanded to way more than that because they started to be able to identify individuals who may be presenting with symptoms at that early age. That's where your prevention comes in. In conclusion, the hospitals and care systems continue to move out of their 4 walls and into community to improve population health and manage the total cost of care. Integrated health care and physical health across all healthcare settings in the community moves an organization towards achieving a triple aim with a patient-centered care model that treats the mind and body. No framework or model of integrated behavioral health is appropriate for every provider. The decision to be a direct provider of behavioral health services or to provide these services via collaborative partnerships, joint ventures, and contractual agreements will be driven by the continuous needs and available resources. The Agency for Healthcare Research and Quality outlined the 3 stages of behavioral health integration: coordinated, co-located, and integrated. Along the 3 clinical functions, client-centered care team, shared population and mission, and systematic clinical approach to guide hospitals and care systems in moving into an integrated integration forward. So one of the slides I didn't include in here, and I should have, is to kind of give you an example of what we at Peak do. We are far from providing a complete continuum of care, but we have an acute level of care hospital for both adults and adolescents. And in that acute care level of care, we have case managers and therapists. Our case managers' primary function is to find out what are the needs of the clients. We link them to insurance care coordinators. We link them to support systems outside of the facility. From the day they get there, we're already looking at what's going to happen when they discharge. We have residential treatment center for adolescents, so if they need a longer term care than acute, then we are looking to place the adolescent into a residential treatment center. And even when they get there, and we know they're going to be there with us for 3 or 4 months, on day 1, we're looking at what's going to help them when they leave our facility. You know, where are they going to go? What is going to be the primary care and support for them when they go? We have our outpatient PHP and IOP, which helps to bridge that gap as well, rather than sending a patient to just a once a month or once a week therapy appointment. IOP and PHP does provide the 5 days or 3 days a week where they get continuous treatment. And throughout the process, we're looking for any family member, any friend, anybody that we can help connect our patient to that will provide some more support, because it's not just about treatment, it's about support. It's about having that additional someone to call in the middle of the night when you're feeling upset and having a difficult time. It's someone to reach out to when you are struggling with not wanting to continue therapy because it gets a little difficult or because you don't have your needs met at home, and who can you reach out to help with those needs as well. So we have the PHP and the IOP programs, which also provide case management services. And through those case management services, they will help link resources for housing, for insurance, for transportation. All of those things are included when we do those different programs. We are also very much connected with agencies throughout the city of El Paso and all of New Mexico that are providing wraparound services. Wraparound services are now linked to your insurance companies as well. So you can contact an insurance company that provides wraparound services and say, I need wraparound. Wraparound will do all of those things. Provide a care coordinator, provide a coach, provide a mentor, provide someone that does regular check-in, provides services such as your therapy, your med management, you're helping them to find AA, helping them to find support groups for depression, helping them to find support groups for grief and loss. And then there are your MST services as well. So there's a lot of different services that are out there for you all to utilize. And the whole purpose of us wanting to be here, for me wanting to be here, and always going to as many conferences as I can, is to link myself with resources, right? Because I am no good to the patients that I serve if I don't know what's out there to offer to them. So the more that you go out to things like this and introduce yourselves to one another and talk about what you do and what services you offer and how you can be of assistance, will help all of us become better providers. It helps if there's family members in here or friends in here that have individuals in their lives that are suffering from substance abuse or mental health issues. Those family members now have a little bit more information that they can take back with them and help whoever their loved one is to get continuum of care for that, for long-term recovery. All right, so let's provide the quality of care needed for those suffering from mental health and substance abuse disorders by coming together to create a network of continuum care providers, which is all of you. And that's all of your resources. Anybody have any questions, comments, concerns? Alrighty, that's all I have. Thank you.